Good evening, everyone. Myself, Dr. Shravani, Clinical Head of the Emergency Department working at Yashoda Hospital, Somajiguda. Welcome you all for today's webinar session. Every Friday, we Yashoda Hospital bring with some interesting topics. The main motto is awareness among the general public. One of the important emergency conditions. So, DKA always remain, and most of the children did have a risk of cerebral edema. So it makes us early recognition and timely management is always crucial. So in the emergency department, our main role is to stabilize, identify the triggers, and prevent the cause. To deliver, Dr. Shaista Ziba, our senior registrar from Yashoda Hospital, Malakpet. Over to you, Dr. Ziba.
Thank you, ma'am. Good evening, everyone. Today, I am Dr. Shaista Ziba, working as a senior registrar at Yashoda Hospital's Malakpet. Today, we will be taking up diabetic ketoacidosis in pediatrics as a topic of discussion of this webinar. Let's start. Okay. How do you diagnose DKA in children? The cutoff age for children is considered here as less than 18-year-old. And the main criteria here first come to the clinical features that point towards DKA are the patient presents with abdominal bleeding, abdominal pain, vomitings and nausea. And along with that, there may be altered sensorium and drowsiness. And the patient has a typical acidotic Kussmaul breathing is noted. When the bedside parameters are checked, the diagnostic criteria with all patients or child presenting with these symptoms are not directly categorized into diabetic ketoacidosis. The three main things that are looked in is acidosis, ketoanemia, and hyperglycemia. Usually, all the children may not present with hyperglycemia. Some of them may be euglycemic also. But blood ketone level of more than 3 millimole per liter, and acidosis, that is pH less than 7.3, or sodium bicarbonate less than 15. So plasma bicarbonate levels of less than 15 millimole per liter indicates DKA in a child. Sugar levels will be more than 11 millimole per liter or 200 milligram per deciliter, but this might not always be seen. With euglycemic or hypoglycemic state also, the child can be classified as DKA. Coming to the, like we have discussed, the clinical features. Clinical signs of dehydration are seen, that is represented in the form of drowsiness, altered sensorium, abdominal pain, nausea, Kussmaul's perspiration. The diagnostics test bedside is blood ketones are done, but if that's not available, then you go for urine ketone testing. You check the dipstick after 15 seconds. It should be read. Minimum 15 seconds you have to wait before reading it. And any more than 2+ sign indicates a more than 3 millimole per liter blood ketone level. But urine test ketones are checked bedside only for diagnostic purposes, but not for monitoring or observation purpose. Classification, severity is classified based upon 3 categories that are considered here again are the pH, the bicarbonate levels, and approximate fluid deficit in a child. Okay, severe DKA, you see the blood pH level is less than 7.1 with a bicarbonate level of less than 5 millimole per liter with a fluid deficit of 10% approximately. Moderate pH is between 7.1 to 7.19, and bicarbonate is less than 10 with a fluid deficit of approximately 5%. In mild DKA also, the fluid deficit is same. It is minus approximately 5%. And the venous pH is around between 7.2 to 7.29. Bicarbonate being less than 15. Here we have an algorithm which actually simplifies things for us. Like we've discussed, child clinical presentation is polyuria, polydipsia, weight loss, a child presents with abdominal pain, vomiting, muscle weakness, and confusion, drowsiness, or altered sensorium can be there. And the clinical signs that we see are signs of dehydration are seen, discus breathing, there is lethargy, that is drowsiness. Okay, and these are all backed up by the bedside test which we do, that is checking the GRPS and the blood gas analysis and urine ketones. Okay. Once this is done, patient is diagnosed with DKA. Then the second thing to notice is whether the child is in shock or not. If the child is not in shock, then you start with bolus IV fluids at the rate of 10 ml per kg bolus. 0.9% NS is started. Okay, or plasma light we can start 148 over 30 minutes. Okay, what if the child is in shock? And now what does it mean the child is shock? How will you know that? Drop in a blood pressure is the late sign. We have to notice and identify the early signs of shock. That includes tachycardia and prolonged capillary refill time, that is more than 2 seconds, and poor palpable peripheral pulses. Okay, so if the child is in shock, you immediately start the resuscitation, going with the classical manner of ABC. Any airway obstruction is there, or the patient is very drowsy, Jesus is low, you manage the airway, or you go for an NG tube if the patient is persistently vomiting. Then for breathing, use any drop in saturation, you go with high flow oxygen. Okay, the next coming to circulation. To restore the dehydration or the fluid, we start with 10 ml per kg bolus is given of 0.9 sodium chloride. And after the bolus dose, you repeat the bolus doses until it is restored, until circulation is restored. That is, BP is more than 90 systolic. Okay, by 40 ml per kg. Okay, once you are done with 4 doses, that is 4 boluses are done. After that, you discuss with the pediatrician for infusions and all. Next, coming to signs of, you have to also notice any signs of cerebral edema. Okay, fine. Bolus doses have been given with 10 ml per kg bolus. You keep repeating it 4 times or until the circulation is restored. After 4 bolus, if the circulation has not been restored, you go for fluid requirements. You calculate the fluid requirement, and according to that, fluid resuscitation is done. Okay, how do you calculate this? According to dkacalculator.co.uk, you use fluids with the 40 millimole per liter potassium. Check serum potassium in normal range and urine output first. These two has to be checked beforehand. If they are normal, NS has to be started with 40 millimole of potassium, okay, per liter. 40 milliequivalents has to be added in the NS which we're giving. And then you start insulin. Insulin infusion is started at the rate of 0.05 to 0.1 units per kg per hour. This insulin should not be started immediately when you diagnose a patient with DKA, even if the patient is hyperglycemic. First thing is fluid resuscitation, then you add potassium, then you go with the insulin infusion. That is 1 to 2 hours after starting the fluid. Okay. Then you also check while we are resuscitating the child with fluids, we have to check for signs of cerebral edema. Like headache, any irritability, any reduced GCS, or signs of raised ICP, or bradycardia. Okay. Any features of cerebral edema, if present, then you manage the cerebral edema. You give 20% mannitol. Okay. 20% mannitol is given to the child at the rate of at the dose of 2.5 to 5 ml per kg. IV fluids has to be restricted by 50%. If there are no signs of cerebral edema, the patient is observed every hourly. What do we observe in a child? You observe glucose every 1 hour. You observe for blood ketone levels 1 to 2 hourly. And hourly neurological examination has to be done. And electrolytes are checked every 2 hourly initially, then after that every 4 hours. Okay. Despite all this, there is still persistent acidosis and the child is failing to improve. Then we manage the acidosis at that point. You reevaluate the fluid balance, require further resusc fluid, anything if the child needs, You calculate that. You check the insulin rate if it is running properly. You consider sepsis and any other differential diagnosis that could be have been missed if we are just going ahead with DKA. Then you consider restarting the protocol. You start reassessing from the start. Okay. Now, during the observations, you've noted that the blood sugar level is less than 14 millimole per liter. You change the IV fluids to 5% dextrose and you continue monitoring as we've already discussed. Once the child is clinically well, the symptoms have subsided and the child is able to tolerate oral fluid and the blood ketone levels have fallen down to less than 1 millimole per liter and the pH has been normal. That is when we consider resolution of DKA. Okay, then we can start subcutaneous insulin at that time and stop the IV infusion insulin that is going on. If the blood glucose level is less than 6 millimole per liter, you manage the falling blood glucose accordingly. Fluids, you change the IV fluid from 0.9 NS to 10 D, and we are not supposed to reduce the insulin infusion that is going on. We are supposed to add sugars, okay? We are supposed to replace the IV 0.9 NS with 10 D. Insulin has to be continued at the same rate until and when ketones have dropped to less than 1 millimole per liter. Coming to emergency management in ER. Okay, this we have discussed already. Okay. So, any patient in ER, the general resuscitation approach is the ABC pattern. First, we check for airway, ensure that the airway is patent. If the child is very drowsy, not arousing, not responding to stimulus, or GCS is low, then we insert an airway adjunct. If reduced consciousness, recurrent vomiting is there, then we can even consider NG tube, aspirate, or drain. If GCS is very low, this persistent vomiting not being controlled with the NG tube, we can even go ahead with intubation as needed. If there is a lot of tachypnea there, CPAP or BiPAP options can also be considered. That is when there's no vomitings there. Coming to breathing, 100% oxygen has to be given by face mask. Circulation, like we've already discussed, you take IV access, take blood samples, take ECG, peak T waves. Usually hyperkalemia, you see peak T waves, so ECG has to be taken initially. BP and heart rate, everything are measured. Vitals are checked. Then investigations in ER, as we already discussed, bedside, immediately you check for the GRBS, blood glucose levels. Then you check for blood ketones if available. Otherwise, you check for urine ketones. Then you check for blood gases, arterial or venous, whatever is feasible. Then other lab investigations that can be sent are complete blood count, CBP, urea electrolytes, and CRP. Okay. If the child is de novo diabetic, then we also go ahead with the HbA1c, CLEX and TFT. Coming to fluid resuscitation, like we've already discussed, if the patient is not in shock, then you give a bolus dose, 10 ml per kg, 0.9 NS over 30 minutes. That's it. Okay. If the signs of shock are present according to APLS guidelines, you give 10 ml of isotonic crystallite over 15 minutes. You repeat the same boluses if the child is in persistent shock even after the first bolus. You keep reassessing. Maximum 40 ml per kg has to be given, and after that you have to consider inotropes also alongside fluid resuscitation. In severe cases, child might need ICU care, so you have to involve the intensivist and the pediatrician also. Now, how do you calculate the fluid volume, fluid deficit, and how much fluid to give? Okay. Once circulatory volume is restored, that is after you have given the bolus IV fluids, maximum like we discussed 4 ml per kg. After that, before that, whenever the BP has been restored, then you go ahead with fluid requirement for the rest of the time. Okay. Deficit and plus maintenance is calculated. How do you calculate the fluid deficit? Fluid deficit is calculated according to the severity of DKA. Okay. Like we've already discussed, mild, moderate, and severe. Mild and moderate, that fluid deficit is approximately 5%, and severe DKA, it is approximately 10%. Now, we use the formula deficit in ml is equal to body weight of the child in kgs multiplied by percentage dehydration multiplied by 10. Maintenance fluid, that according to Holiday Cigar method, is calculated according to the weight of the child. Okay, 0 to 10 kg, the maintenance volume is 100 ml per kg per day. 10 to 20 kg, it is 50 ml per kg per day, and more than 20 kg, it is 20 ml per kg per day. At what rate the IV fluid has to be given? Then we follow the deficit minus initial bolus divided by 48 hours plus maintenance per hour. Maintenance we have already discussed in the previous slides, in these slides. Okay. So, for example, if you have a 20 kg child who's around 11-year-old and the pH is 7.15, that means moderate DKA. Okay. And the deficit is 5% in moderate DKA. Will receive a 10 mg bolus already has been given. Okay, that is 10 mg per kg, 10 mg for 20 kgs, 200 ml fluid over 30 minutes as a part of initial management. Then we have to go ahead with the on. Okay. Step 1. How do you first calculate the fluid deficit? How do you calculate it? Deficit in ml is body weight in kg multiplied by D percentage dehydration multiplied by 10, like we've already discussed. Okay. Then, like in this child, 20 kg child, percentage dehydration is 5%. So the deficit here is 20 into 5 into 10, that is 1000 ml. Now you have to adjust the fluid deficit calculation. What do you mean by that? 100 ml minus 200 ml, that was the bolus that was given, is 800 ml. Okay. So this 800 ml should be replaced. How should it be replaced? Evenly over 48 hours at the rate of approximately 17 ml per hour. Daily maintenance fluid calculation. How do you calculate for this child? For the first 10 kg, like we've discussed, we need 100 ml per kg per day, which is equal to 1000 ml. For the next 10 kg, 50 ml per kg per day, that equals to 500 ml in this child. What is the total daily maintenance fluid requirement? 1500 ml per kg, which is approximately 62 ml per kg per hour. So total hourly, now coming, this was fluid calculation per 24 hours, every 24 hours. Total hourly fluid rate calculation is the deficit rate is 17 ml per hour. The maintenance rate for this child is 62, and the total hourly rate is 79 ml per hour. Okay. Okay. What are the things you have to consider while you are resuscitating the fluid resuscitation is being done? First thing is you do not replace the urinary losses. Okay. Do not give additional IV fluid to replace the urinary output. In a child, usually a urinary catheterization is avoided, except if the child has impaired consciousness or accurate urine output monitoring is essential. Do not give any oral fluids. Ketosis is resolving, nausea, vomiting have settled, then you can go for oral fluids. Till then, it's only IV resuscitation. Okay. NG tube may be needed if there is gastric paresis develops, and any oral intake before 48-hour rehydration is complete. First, rehydration has to be done for 48 hours. Till then, oral intake has to be reduced. After that, it can be given. And then the IV rate can also be reduced proportionately to avoid the fluid overload. Okay. Coming to potassium management. all the fluids except the initial bolus. The initial bolus which we are giving, that has to be potassium free. After that, whatever fluid we are giving, we have to add potassium in that, because the insulin infusion and the IV fluids tend to cause hypokalemia. So all the fluids should contain 40 millimole per liter potassium chloride. So potassium replacement has to be done in all the kids except those in renal failure or whose serum potassium level is more than 5.5. You do not do potassium replacement in that. And hypokalemia may develop up to 48 hours after starting treatment. So potassium has to be monitored every 2 hours or 4 hourly, and accordingly, the potassium replacement has to be done. If hypokalemia develops, that is, the potassium is less than 3 millimole per liter, despite giving potassium with the IV fluid, then you have to stop the insulin infusion temporarily, and you might have to increase the potassium from 20 millimole per liter to 40 millimole per liter. Oral can be considered only if only the child is able to take orally, only then, otherwise no. When do you add potassium? Like we discussed, if the potassium is, let's start with the least. If the potassium is less than 3 millimole per liter, you do not start insulin. Okay, until the potassium is more than 3. First, you have to replace potassium. Once the potassium is more than 3, then you start with the insulin infusion. Then if the potassium is more than 5.5 millimole per liter, then you delay adding potassium until the patient passes urine or potassium falls below 5.5. Okay. If the potassium is less than 5.5 millimole, then you add 40 millimole per liter KCl to all the fluids. Basically, the potassium level which we are seeing here is 3 to 5.5. In this range, if the child's potassium is in this range, only then we replace potassium. More than this, you do not replace potassium. Less than this, you do not start insulin until potassium levels have been increased. Insulin therapy, okay. IV insulin has to be started, like we discussed, 1 to 2 hours after the IV fluid therapy has started. You do not give insulin bolus doses because bolus insulin doses are not appreciated in DKA. It can cause pulmonary cerebral edema. Okay. You can go ahead with pre-filled insulin syringes are available, 50 units soluble ectropid and 50 ml of 0.9 ml NS. If not available, then you can manually prepare the infusion, 50 units in 49.5 ml of 0.9 sodium NS. Insulin therapy, how much to give? Most children, dose is 0.05 units per kg per hour. That is a preferred starting dose. Severe DKA or in adolescents, you can go ahead with 0.1 unit per kg per hour. There has not been any significant difference between the two ranges actually. But if you start with a lower dose, you can reduce the risk of hypoglycemia in a child. Continuous monitoring. Once the patient, okay. Now continuing, the patient, the fluid resuscitation has been done. Potassium is in normal range. Sugars are in normal range. The continuing management includes monitoring and ongoing care. Hourly monitoring of vital signs, blood glucose, and cardiac monitoring. If potassium is abnormal, continuous ECG has to be taken every hour. Every 2 hours, you have to check the blood ketones, not urine ketones. Every 4 hours, you do the VBG or ABG is done to check for pH and bicarbonate levels and electrolytes. Okay. Glucose management. Once there is hypoglycemia, if the sugars have dropped to less than 6 millimole per liter, then you increase then you replace a 0.9 NS with 10D. Like discussed, if the sugars are less than 14 millimole per liter, then you change 0.9 NS to 5% dextrose with KCF. If it is more than 14 millimole, then you do not add. Then you continue with your 0.9 NS with KCF. Okay. When do you say that DKA is being resolved? Their criteria. pH has to be in the normal range. It has to be more than 75. The bicarbonate has to be more than 15. Blood ketones has to be less than 1 millimole per liter. Not feasible, then urine ketones can be done less than or equal to 1 plus. Okay, on the dipstick. The child is able to tolerate oral fluid and is clinically well and alert. Clinical improvement in the child has to be seen along with the lab parameters. That is also very essential. Then once the child resolution of DKA has been done, the IV insulin can be stopped and can be transitioned to subcutaneous insulin. How much to give? IV insulin has to be continued 30 to 60 minutes after first subcutaneous dose to prevent rebound hyperglycemia. Okay. Then basal bolus regime, according to the scale, insulin has to be given. Discharging the patient, educate the family on sick day rules. Home ketone monitoring has to be done, and any clinical features the parents has to be educated. So the child is brought to the hospital early. Ensure that there is a diabetes specialist nurse and dietitian review before the discharge. Schedule a follow-up with the diabetes team within 24 hours. Warning signs in DKA. Cerebral edema, like we've discussed, cerebral edema, what are the symptoms? There is headache, there is bradycardia, and there is unequal pupils, okay? How do you manage cerebral edema? You stop insulin, you stop IV fluid, you give the child mannitol. Mannitol at what dose is given? 1 gram per kg IV over 10 to 15 minutes. It reduces the intracranial pressure by drawing the fluid out of the brain. Then you give hypertonic saline, 5 to 10 ml per kg over 30 minutes. It increases the blood osmolarity, drawing the fluid out of the brain again. The child has to be in PICU. A PICU referral has to be given immediately. So coming to the summary. First thing, fluid replacement. Fluid replacement has to be done after the bolus doses gradually over the 48 hours. Then add glucose if the blood sugars have dropped below 14 millimole per liter. Keep monitoring ketones and electrolytes very closely. Every year, 2 hourly ketones and electrolytes every 4 hourly. And you watch for any signs of pulmonary edema, cerebral edema. So, okay. Insulin overlap. Overlap IV insulin with subcutaneous insulin during the transition. When we have started the subcutaneous doses for 30 to 60 minutes, IV infusion has to be continued so that there's no rebound hyperglycemia. Okay, thank you.
Yeah, good evening all. This is Dr. Raghu. Yes, Aisha, you are there?
Yes, sir.
Yeah. So that was a good talk, Dr. Saista, because pediatric exposure to all of emergency physicians will be less compared as we have the adult, because unless until you work at a pediatric hospital where you see a lot of pediatric cases coming, so it will be not that much easy to treat the pediatric cases and whatever emergencies they come. So as Dr. Saista said, the first, what will be the diagnostic criteria, the initial assessment, the fluid management, the insulin therapy, whether it can be a electrolyte management and prevention and management of cerebral edema, disposition and follow-up, and the to add this, so I want to summarize in a short nutshell. It is early isotonic fluids with a careful fluid replacement before we start the insulin. So fill the tank before we start the insulin, and insulin only infusion. So don't give boluses as we give for the adult patients. So this too only after the initial hydration. So after the hydration only you have to start your insulin infusion. And aggressive electrolyte correction, and especially the killing thing is your potassium has to be monitored, and vigilant monitoring of the cerebral injury. So in children, they may express the signs of the raised ICP, and this has to be monitored in a delicate manner. And avoidance of soda bicarb in routine management of your acidosis. So some people have the fantasy of giving soda bicarb for correcting the acidosis. So there will be no role of soda bicarb in the DKA unless until your pH goes down 6.9. There will be no role of soda bicarb in the pediatric DKA. And so there will be some differences between the adult and children. So extra cautious of IV fluids when you're dumping the fluids, no insulin boluses, early and aggressive electrolyte correction, and continuous neurological monitoring. So whether the child is dipping into the cerebral edema. So Saista, you want to add anything?
No, sir.
Yeah. So any questions from the audience? Dr. Saista will be ready to take. So if there are no questions, can we end the session? Anybody there? So I thank Semi and Anbai. And as we all know, Yashoda Hospitals, every Friday we bring up the fourth interesting, relevant, and up-to-date topics in the field of emergency medicine, which will be discussed by our experts and moderated by our seniors to guide for the students, the residents, and the registrars. So if there are no questions, can we wind it up? Anybody there?